We're here at Myeloma 2022 in Scottsdale, Arizona. I'm Keith Stewart. I'm one of the organizers of the meeting and currently working in Toronto, Canada. I'm joined by Professor Gareth Morgan, a co-organizer with me from New York University Langone Cancer Centre, and Dr. Faith Davies, who's also been chairing one of the sessions today and presented. So we're going to just have a recap of today's event and what the highlights were for those of you who are listening. And we'll maybe start backwards, because I thought the last session we had today was probably one of the most interesting, which was talk about minimal residual disease in myeloma and the different technologies that are being employed. Gareth, what were your reactions to that?
So I just see the utility of using mass spec going forward. We've been addicted to molecular tests and next generation flow. But going forward, it looks like within a year, we'll start to have a technology that's applied or applicable to the peripheral blood that has great sensitivity. And if you measure at key time points, like 3 or 9 months after a transplant, you can predict how people are going to do long-term and adjust therapy appropriately to make outcomes better. It's great news.
And it's just a blood test, it's not
just a blood test.
And I remember when I was at Mayo Clinic and it was first being developed, the other thing is it takes 15 minutes to run the test, so really incredibly efficient and simple. Faith, what were you taken by in that session?
I really enjoyed Raphael Fonseca's talk. He put some really good kind of thoughts out there along the lines of, we're all getting worked up about, is MRD kind of formally approved for all of these things, and he kind of pointed out that we're all very comfortable using serum-free light chains to measure response, and that we're very comfortable using those to kind of change our therapies and so on. So why are we getting so upset and so kind of concerned about using MRD as a test? And so I thought that was really...
some people are really quite slow to adopt the technology, seem irrationally reluctant to adopt it. Are you using it in your own practice?
Yeah, so we use it a lot. I think it's really
flow
informative.
cytometry or sequencing?
So we've been mainly using the sequencing method, and we've got the flow cytometry up and running too. For us, the flow is probably a little easier because sometimes, because of our referral systems, we have issues getting the diagnostic bone marrow. And so kind of the flow method seems to be quite a good one. But yeah, very, very happy with it.
Of course, that still requires bone marrow. And the beauty of today's talks towards the end were that you can do this on a peripheral blood sample, which people challenge the sensitivity and specificity of that, but one of the things I always think about is if that's positive, you don't need to do a bone marrow. If it's negative, you can still go and do a bone marrow if you're worried about sensitivity. So what did you think about using whole genome scanning as a technology, Gareth?
So I really like the idea about measuring the number of genomes in the blood using a scanning technology. The issue is that in a disease like myeloma, the sensitivity is going to be limited by the number of genomes that are in the blood. So my suspicion is that that's not going to work out as sensitive as mass spec. And so I actually think mass spec is going to come to dominate and be the routine kind of diagnostic approach for looking for MRD.
And Dr. Dispendiary showed some other advantages, which were you could distinguish the drugs, the antibody drugs, from the tumor. You can distinguish the tumor clone from regenerating clones after transplant. And she didn't talk about it today, but I know that they're working on forms of the protein that are amyloid, that cause amyloid, and glycosylated forms of it. So that's also going to be very interesting. So the session before that was on new drugs. And for the audience, what did we learn there, Faith?
So we had a couple of talks in there. So we had a number of talks about IMiD resistance and how that can occur.
For the audience are Revlimid, pomalidomide.
Yeah, Revlimid, pomalidomide, but they're also talking about some of the newer IMiDs, CC220 and 91248.
248.
Yeah, no, all right, nearly there. So that was very interesting. Had a great talk about immunogenic cell death. And how important that is for many of the drugs we've been using for years, like proteasome inhibitors, but also for some of the newer drugs. And I found that particularly interesting because Ken Anderson was saying that in the high-risk patients, it may be that those cases are unable to use immunogenic cell death, and that might be why they're more high risk. So that was great. We had a really nice talk from Suzanne Lench about new therapies for amyloid and how they're using similar approaches with bispecific antibodies and also reprogramming macrophages to kind of kill off amyloid cells. So that was good.
There seems to be more and more mounting evidence that what we've always thought of as being directly cytotoxic drugs may in fact work in large part through the immune system, including the immune modulators and maybe even proteasome inhibitors, which we never really thought about in the context of immunity. What do you think?
That was a great point of today, that a lot of the drugs that we use are actually utilizing the immune system, and building on that with these newer drugs makes every bit of sense. But I really was taken with Susie Lench's talk about modifying monocyte macrophages with chimeric antigen receptors in those cells to have them recognize amyloid deposits and go to those and then eat up the deposits and then have people's organs get better. I mean, I thought that was really a novel.
We'll hear more about new drugs tomorrow, of course. The last session in the morning was about single-cell sequencing, so it was probably the most technology-focused, but what were the clinical perils that you took away from that? Either of you that wants to answer.
So I thought it was a great session. That was like all of the single-cell data was presented. It's still got a long way to go. Dr. Gabriel's 200 patient samples is going to be a useful data set. But currently, it's not delivering what it should be delivering. I think we have to really work hard to understand what's going on and not just have correlations between points of disease, the number of bad cells, and the number of immune cells. There was quite a lot of that correlative science, and we really need to do investigative science where you change something and see.
One thing that struck me as quite new was Roger Tiedemann's talk, where he talked about oxidative phosphorylation and reactive oxygen species as being a dominant feature driven by amplification of chromosome 1, which we have struggled to understand what the significance of that is. Did you buy into the story there? Or?
Yeah, so I mean, I'd actually been to a different meeting last week at our cancer centre, and the oxidative phosphorylation is like the buzz kind of area now in solid tumours and in radiation oncology as well. And so there's a lot of work now going on about metabolic reprogramming and metabolomics. And so I'm kind of really interested not only in what Roger's doing at the moment, but kind of that next step of looking at what the differences in the metabolomic profiles between those two.
Well, I was going to come to that. So the last session we should discuss briefly was the opening one, which was on the genomics of myeloma. And I guess I've asked you this before, Gareth. Do you think we've tapped out what we can learn from genomics? Is it time for metabolomics now?
I think that would be a bad move to give up on genomics about now. I think it's just starting to deliver, and as we introduce new treatments, exploring the immune, the sort of molecular impacts of those treatments is going to be really important.
The first session of today was on genomics, and we, given what Faith just said about the importance and emerging importance of metabolomics in cancer in general, and myeloma. Do you think we've exhausted what we'll learn from genomics, Gareth?
I think we're only just beginning to tap into what genomics can teach us, and the use of signatures and timing of origin of the mutations. I think there's a lot to learn in that, and I think the next year or two we'll see a number of new stories emerging, like the role of APOBEC signatures and how that modulates disease in different ethnic groups and different risk strata of disease. So I think we're at the beginning rather than the end.
What did you take away from that session, Faith?
I can say one of the talks I really enjoyed was from Leah Rascher from Würzburg, and he essentially was talking about kind of the genomics of myeloma and comparing it to how the coronavirus has emerged over the last few years. And he was looking at parallels and similarities between the two. And number one, it was a real kind of cool way to think about myeloma, but his thought process was incredible. And one of the stories he was talking about was he was able to give examples where he felt there was like a patient went into more or less MRD, but there was like one single cell that was left, and then that came back to kind of really take over in the long run.
I feel like Gareth's been talking about this for a decade, though, the evolution of the cell and this small clones emerging under drug-selective pressure. Do you think it was that new? Or?
I think we've both been talking about it for a decade. But this was a good spin on it, which really showed that it works.
Especially when you're explaining to a non-expert, like parallels with the emerging variants of the COVID virus. Yeah.
It's always much more interesting when somebody other than your other half says something, isn't it?
Yeah. Well, he's usually wrong. Thank you, everybody, for paying attention. This is the end of day one of our Myeloma 2020 meeting on the innovation in biology and myeloma. We'll be back tomorrow on day two, and thank you for listening.